The Knee Gurus, the latest research and advice from industry experts for best practice management on knee injuries and pain. Here's your host, Bevan Colless.
Hello everyone and welcome back to the Knee Gurus for another episode. Great to have you all back. One of the main goals for this podcast is to try and help empower people who've recently injured their knees to make the best possible decision for their own future management. Now, one of the most exciting developments in ACL management in many years came recently with the publication of the cross-bracing protocol in the British Journal of Sports Medicine. This has changed how a lot of fundamental beliefs about the ACL, and one of the most important is whether it can heal or not. So often it was previously believed the ACL did not have the ability to heal. But we're finding that it almost certainly does. And the ability for the knee to heal may be enhanced if the knee is kept in certain ranges of motion for certain periods of time. And so far, the researchers have published the results of the first 80 people that went through the protocol in their case series. And they achieved the remarkable healing rates of 90%. 72 of the 80 people had fully healed ACLs at the end of their protocol. Now, one of the first participants in this study was a fellow by the name of Dr Steven Duhig, who ruptured his ACL, and we're lucky to have Steven with us today. Just as a introduction, Dr Duhig he's in the industry, I guess you could say. He's a sports scientist who received his PhD in 2017 with some research focusing on hamstring strain injuries. And since then, his research interests have broadened to include identifying determinants of athletic performance and personal training programs to optimize sports performance. His current research is involving the connections between muscle architecture and injury risks, as well as performance enhancement and injury prevention. He's also interested in developing technology to improve musculoskeletal imaging and function, and the goal of his research is to provide practical applications in the field of sport and exercise science that directly improve clinical practice and athlete outcomes. So that's a professional background of Steven. But Steven, welcome on board. Can you tell us a little bit about yourself?
Yeah, thanks, Bevan. That was you've summed it up nicely in terms of my professional bio. So yeah, I guess from my background and how I was introduced to the cross-bracing protocol, I was down playing soccer, social soccer, of course, six-a-side down at the university's field, the grass field within the athletics track. And things got heated as they do with social soccer, and fell over and twisted my knee, so to speak, and it dropped me, and that's where it all began. So I guess I was fortunate being in the industry. I identify as a strength and conditioning coach, but my bills are paid through my work in academia. So I'm a lecturer at Griffith University, as you alluded to, in sport and exercise science, and I've worked in the elite setting, and I've also had plenty of interactions with those at the elite level through my own research, be it hamstring injury or some of the performance stuff that we've been dabbling into recently, and build a professional network that essentially has given me the latest and greatest in terms of science. So I was very fortunate that I had a network, and as soon as I did my knee, I sent a message to a colleague, Dr. Luke Eggleston, a sports physio. Sorry, yes, he is a physio, but he also upskilled and became a sports physician. So I sent him a text and I said, mate, what do we got? I was 36 at the time. I said, I don't want surgery. I wasn't happy with the outcomes of surgery. Everyone that I'd spoken to, you look at the literature and the percentages they vary in terms of the outcomes. But everyone you talk to seems to have an issue with their surgery. A shelf life of 10 years, I wasn't happy with that either. So I sent him a text and said, what do we got, mate? Like non-surgical approaches. Is there anything out and about? And obviously, as a sports physician, he's got his finger on the pulse. and he said, mate, there's a guy down in Sydney and they're bracing these knees and they're healing. And, as you were mentioning in the introduction of the podcast, that's rubbish, right? That's hocus pocus, that's sort of your snake oil stuff, like rubbish. ACLs don't heal. Like, you've got to go under the knife and they've got to be fixed through reconstruction, right? So didn't believe it, but so be it. I went through with this protocol and voila, magic. The human body, it can heal itself. What a surprise.
And that first reaction of yours, that you were sort of against surgery as soon as it happened, that's a little bit of an unusual way of thinking. Most people tend to think, I've done my ACL, I've heard about that on the news, I need surgery. What do you think led to your sort of alternative way of thinking about that? Was it your professional background, or was it just the way that you tend to think? Are you sort of a contrarian, would you say? You're generally someone who's happy to go against the flow of general opinion, would you say?
Yeah, mate, I'm a bit of a cowboy, if you like. No, I as I alluded to, I wasn't happy with the rates. With the the recurring injuries, or they slice and destroy one of the knee muscles to fix the knee, and to me that doesn't really make sense, because we see all these hamstring strains pop up, or if you use the quadriceps or patella tendon, then we lose some of the force and some of the strength and power of that muscle group. So to me, it didn't make sense to go under the knife. I don't like general anesthetic. It's a bit of an insult to the brain every time you go under. So I'm not a fan of surgery. And I just wanted to see if there was something else. And being a scientist, I'm always keen to, curious to see whether we can try alternative methods. And if there is that opportunity for me to be the guinea pig, I ask many other people to volunteer their time and essentially be the guinea pig. So if there's a chance for me to jump in and try something exploratory, then I'm all for it. So curiosity got the better of me, and I jumped in. I'll say blindly, and only for the fact that there was no peer-reviewed scientific literature, and that was a flag. But I had comfort in the way of Merv Cross, Dr. Merv Cross, who received the Medal of the Order of Australia, which is one of our high achievements, through his revolutionary knee surgery. This was his idea. 50 years as an orthopedic surgeon, he was the man, the go-to man. If your athlete or anyone tore their ACL, go see Merv. He's the best that we've got. But then also his son, Tom Cross, and of course Cross being the name, the last name of the founders, rather than the characteristic. I was thinking the bracing must look like a cross of some sort, but no, it's the surname of the doctors that found it. And Tom was actually the head physician at the Sydney Swans, which is an Australian football team, an AFL team here in Australia, and of the elite level. So he was looking after those guys. So there were runs on the board in terms of reputation and guys that know what they're talking about and know what they're doing. So I took comfort in that, and as I said, curiosity got the better of me, and I wanted to explore non-surgical paths. And look, I was number 42 in the world to put my knee in a brace to see its healing potential on the ACL.
And could you just run us through how those first sort of couple of weeks, which we're understanding is the critical healing window from the time you ruptured your ACL to the time that you would put in the brace and deemed to be a suitable candidate for the cross bracing protocol? What was that time frame, and what happened in that time frame?
Yeah, so I did my knee. I knew something was, obviously something was wrong. It dropped me. I limped over the sideline, sat there for the remainder of the game. It was the end of the first half, and then I sat there for the rest of the second half. And of course, classic ACLs, right? You then get up and walk off like nothing ever happened.
Yep.
So that happened, and I walked back to my car and drove home. At home, it blew up like a balloon. And if I pivoted, that's when I'd have those instability issues. So I knew something was wrong. I couldn't flex my knee. I was hoping it was just going to be meniscus, but in the back of my mind, it was the ACL's done. I got into a GP, a general practitioner, just a local one. I went in there and he did this very unconventional clinical assessment where he tapped the top, side, bottom, and the other side of my knee, asked me if it hurt. And each time I said no. And he said, well, you haven't done your ACL. And
Is that the same day or the following day?
That was a couple of days later that I was able to get into him. So, I wasn't quite sure of the time frame at that point, but time is of course of the essence when it comes time to bracing after an ACL rupture. But I convinced him to put me in the MRI machine and scan my knee to see if it was an ACL. And of course, on the slip he said maybe ACL, and I was like, oh. Anyway, so I got into the machine, and it confirmed, worst case, that I'd torn my knee. And I sent a message again to my sports physician colleague and friend, and he put me in contact with Tom, who was vacationing over on an island off the coast from Sydney, Lord Howe. Very, very bad internet over there, poor bandwidth. So he ran me through the protocol, the presentation, beautiful presentation, really enjoyed it. And essentially he said, you've got 2 weeks. And I was at about day 8 after rupture at that time. So I really didn't have much, and it was getting close to the weekend. And, you've got to find that brace that locks at that specific range and has the ability to change the range as you progress through the protocol. But he said 2 weeks, you've got to be in the brace. Otherwise, if this is your ACL and it tears, they then start to form stumps, and then they won't be able to heal. So in the lead up to that, I had to find the brace. I had to go and get an ultrasound, a Doppler ultrasound, to ensure that I didn't have any deep vein thrombosis, any DVT, any clots in the lower limb. That I went and did that. That was all clear. I got my brace. I threw it on, and then I made sure that I had a prescription for Xarelto. Obviously, when we immobilize the limb, we increase the risk of clotting, which is why we first get that Doppler ultrasound. And Xarelto just thins the blood to reduce the risk of further clotting. So 2 weeks at that point in time was the where you needed, that was a threshold. There's been some cases that Tom's mentioned, 3 weeks, and they've been okay. But really, you want to try to get that in the knee in a brace as soon as possible. Obviously, confirm ACL, make sure there's no clotting, have your Xarelto, your blood thinners ready to go, brace, and away you go.
Was there any?
I'll be honest.
Sorry to interrupt. Was there any interpretation of the MRI to decide whether your particular type of rupture made you a suitable candidate?
Yes. So at that point in time, be it 42, they didn't like avulsions. So my diagnosis, the interpretation of the MRI, was an avulsion, ACL avulsion. So it tore from the femur, completely tore. Tom said, Dr. Tom Cross said that they prefer a proximal third tear. So, the top of the ligament tears, and you've still got some of those fibers attached to the bone, a third of that ligament attached to the bone, and the 2/3, attached to the tibia, so that they can essentially find themselves and heal. So he said, Steve, we've had 2 with avulsions. We've had 1 anatomical heal, which means perfect, and the other was a good heal. It wasn't great. There's a bit of slack in there, but still it found itself. And I said, Tom, let's flip the coin then. I'm keen to have a gamble, have a punt. Let's see if we can to change the odds to favour the avulsion. So he subsequently had his radiologist down in Sydney have a look, and we have two bundles of the ACL, the anterior medial, posterior lateral. But his radiologist said that just one of those bundles tore from the bone, completely off the bone, and the other one was that proximal third. So it still had some fibers attached to the thigh bone. So there are characteristics that determine whether you're eligible or not, and it's preferred that it's not it doesn't tear straight off the bone. There's still some fibers on the femur. But then also, if those fibers break through that synovial envelope and flip forward, then it's not going to have the same healing potential either. So that's quite easily determined through that MRI to see whether there are any flipped bundles anteriorly. So there is a criteria that you need to meet, but it's, I guess it's all just dependent. You will still heal. It'll find somewhere to attach to, but it's just about the integrity and the strength of the knee and the ligament moving forward.
Yeah, one of the problems I guess people are facing is trying to find a radiologist or a sports doctor or a physio with the ability to read the MRI to that extent of detail and even categorize the different types of tears, which is a growing area. And I think some of the areas that the cross protocol is looking for further research, where they can be really, really accurate in deciding if somebody is a suitable candidate or not. Because obviously, if you go through the bracing protocol and you find out it hasn't healed, it's pretty gutting. So I guess in your case was you got onto the right person at the right time, which made all the difference.
Yes, yeah, it's who you get to look after you is obviously the most important part, and the interpretation of that MRI. Even the first radiologist that looked at it said complete avulsion, and the second radiologist said, well, one bundle as avulsion, the other is a proximal third. I guess it's I hear about these healthcare systems throughout the world, be it America or England, NHS, and from reports, you're looking at a couple of years before you can even get in for surgery. So I think in that case, if you if you get MRI, you're not completely sure whether it's flipped forward or not, or an avulsion, I guess you want to try something anyway, right? You can always go under the knife at a later date, but you can't really opt for a cross bracing if you go under the knife first. So we hear about these copers and non-copers, and I've heard about many more instances where you get this spontaneous healing of the ACL without bracing. So I think it's a matter of making sure that you find someone that is skilled in ACL rehabilitation through non-surgical paths. There's one of my colleagues over in Western Australia, Kieran. He's big on those non-surgical routes. So I think finding the right way, and I think the key, even if you don't brace at 90 degrees, and obviously that's the rationale behind that 90 degrees is because it puts the two attachment points of the ACL at the shortest distance. So essentially that ligament is slack. And when you're between 10 and 30 degrees of knee extension, that's when it's taut. So even if you can try to avoid that 30 degrees of knee extension, for the first, 5-6 weeks, then I think, that's going to put you in a good position as well. There are obviously mobility issues associated with the brace. You've got to have it locked at 90 degrees for 4 weeks. So getting around, you're on crutches, you can't drive. There's a couple of times I slipped on the concrete and landed on that knee. It's it is a big commitment. So I think this is really while this might be a really great way to heal the knee, I'm sure there are going to be other protocols that that pop up in regards to trying to make it a little bit more feasible for some people. If you're a mother of 3 or father of 3 young children, and you've got to run around and try to get these kids, then hopping around on one leg with crutches might not be the solution.
Yeah, or if you've got to drive for work or the area where it's too difficult to get around on crutches. So on that note, I understand there is a Facebook group with people going through the cross bracing protocol, sharing ideas on how they manage to cope with having their knee at 90 degrees. How did you find it? Did you have any tricks or tips on how to get that working?
Yeah. The Facebook page popped up after I'd been through the protocol, but that's that support networks are critical. It's so important to have people there to lean on and talk to, and there's tips and tricks. But for me, it was yeah, I mean, you just got to try to get through it, right? It's in my mind, it was always either this or go into the knife, and I didn't want to go into the knife. So, it is what it is. You got to keep your knee at 90. You wore through the little rubber stoppers on the Canadian crutches.
Okay.
Like there's no tomorrow. It's but you just got to try to manage it. There's not really any, in my opinion, any tips or tricks. I kept my sanity through going to the gym. I'd previously just had all the equipment here at home. I only got a commercial gym membership. I got a wheelchair dropped off by a Paralympian, so I could do some conditioning stuff. It's just about trying to find what works for you and just being adaptable.
And how did you? I guess one of the criticisms of the protocol is that it's too difficult to keep in 90 degrees, and the risk of DVTs hands that we talked about earlier, as well as, I guess, probably the number one criticism is the muscle wastage and stiffness in the knee. But I understand you obviously have a better understanding of exercise than most. How did you sort of manage the prevention of muscle loss and stiffness while you're in the brace?
Yeah. So it's just following exercise. I was very thorough with my rehabilitation and exercises. It's something that consumes you. As soon as you're in a brace and you're on crutches, every conversation is centered around, oh, what happened to your knee? And all you do is just talk about your knee all day, every day. So, I was very diligent with my exercise. I'd make sure, in the knee, I was doing what I could, be it isometrics, co-contraction, quadricep, hamstring. So I'd be holding, I'd be performing these isometrics every day, at least 10 minutes per day, twice a day, most days. I'd be doing whatever I could. I'd be doing, bent knee, obviously, with my, plantar flexion. So just pushing my heels, pushing my toes against a TheraBand. I'd be doing hip stuff, and I'd be doing it to failure, or I say failure, but I'd be doing it to such high volume, such high repetition, as a way of trying to get that metabolic stimulus for muscle hypertrophy. I was in the gym as well, machines. I couldn't train at home anymore because I don't have any machines here. So, the pin machines that you see at the commercial gyms, I was doing the contralateral exercise as a means of trying to keep that strength there for when I, return, or I can start doing some resisted stuff in the gym. So yeah, it's just about, in my mind, it was about using that metabolic stimulus. So performing very high repetitions to get that, I'll say pump, but to get those metabolites built up in that limb, which would then, as we know, is a stimulus for hypertrophy. So it was a funny one. I had the first 5 days, I didn't really do anything when it was in the brace, and I was taking circumferences, and I lost 4, 5, 6 centimeters around my quad, around my thigh, and also around my calf. So there was clear, atrophy, but probably in the way of just some fluid shift. I then started, those very high volumes, high repetition exercises, be it isometric or dynamic. And I actually found that it returned quite quickly. And looking at the leg, like depending on what I was using, what muscles I was targeting, there was sort of this selective atrophy. Like if I, through sartorius, you could see that it was, it wasn't the same size as the uninjured limb. But yeah, it seemed that, taking that approach with, really high repetitions but low intensity saved my muscle mass. And when I jumped in the DEXA, to look at my body composition in week 13 when the brace was off, there was no difference between limb and my left and right, or injured and uninjured side. So it seemed that the approach that I took with high volumes was it worked.
And did you do any other testing aside from the DEXA? How was the functional strength in and the range of motion stiffness in the affected knee?
Yeah, so I'm fortunate enough that I had an isokinetic dynamometer which is gold standard for strength assessment. And I jumped on that. I didn't get on it immediately. Like I was doing, as soon as I injured, so 2 or 3 days after I tore my ACL, I jumped on there and I tested my left leg. And I know I'm fairly symmetrical with my strength, so I was confident that my left leg would be similar to my right, which was the injured. And I had that, so immediately I had those baseline measures. And then it wasn't until about week 20, 21 after my injury. So I didn't start open chain exercise, which is, your leg extension, that machine at the gym, or your knee extension, whatever you want to call it, where you're pushing the lever away. So I didn't start any of that open chain exercise until week 17, just purely because the ligament is, it's an infant. It's, it doesn't have that strength, that integrity. So I waited until week 17 after the initial tear, the night of the injury. And then I tested around week 20, and it was just outside of the 10% difference between limbs. So it was already well on its way. And look, I put that down to making sure that I still did that really heavy, high intensity strength training on the left uninjured limb throughout the whole duration of that rehabilitation, just for that transference, that strength transference between limbs. And then, of course, while you don't get that same strength adaptation, but the very high volume repetitions that I was performing, I believe, also helped. So it wasn't, I think it was week 25, and then it was, there was the symmetrical between limbs with, knee extensor, knee flexor, and then the functional stuff. I was hopping, and I was really pushing the boundaries in terms of seeing how quick I could return. I surf and play footy, and I say football, Australian rules football, and I wanted to see how quickly I could return. And look, I knew, less than 9 months, you increase your odds. Less than 6 months, the odds are really stacked against you in terms of tearing, re-injury, or injuring the contralateral, at least with your ACL reconstruction.
Yep.
So I followed the Melbourne ACL rehabilitation program, which was suggested by the guys down at Sydney, Tom Cross and colleagues.
This is after you came out of the brace, you kind of hopped into a certain stage of the Melbourne guide. Is that
right? I just based it off, what I was, how I was feeling, what it was like. But at, week 10, I was able to back squat, 100 kilos for 5 repetitions. I was performing. They weren't A skips, though. It was more of an A march, but I could still get pretty much through that terminal extension, knee extension. To me, there was a couple of degrees off that I really worked on. But it wasn't quite there. But my strength regained really, really quickly. It was amazing. And
it's really a brilliant idea that probably people don't know enough about, is that transfer from doing loading on the uninjured limb. We'll actually see strength gains on the injured side. So I'm sure that really helped you, and probably something that most people don't work on enough.
Yeah, I agree. It's it's imperative in my mind. You've got to have that. We see that transference to the strength, but I think it's it really does come down to how diligent you are, how thorough you are with your rehab. So making sure that, in my mind, I'm active. So every day I'm doing something. So rehabilitation needed to be the same. You obviously just regress it. You've got to regress it right back, to step one, and then you build from there. So I think it's very important to make sure that you scale it right back, and then of course you build as you're meeting those markers to take you to the next level. I think for me, I believe that I've got a fairly good connection with the body and understanding, and it's just about pushing through that barrier, but not too much. And it's hard, when there were times where I was in pain and uncertain, but I'd still push. But I believe that I was safe, and I guess that's the tricky part, especially if you've never done your knee before, which I hadn't. But it's just about trying to do enough, but not too much, if that makes sense. So I think having I'm fortunate because I've got a PhD in the field. But it's really important to find that support network, like the Facebook page, or someone that is skilled in ACL, that is a specialist in ACL rehabilitation. I think that's a must-have.
Yeah. I mean, I always say to patients, that's really our job as physios, is to find that fine line where we're challenging the joint and the muscles to the right level without inflaming them and having them set back. Did you have any of those setbacks as you were rehabbing, where you sort of maybe pushed the knee a little bit too hard on one workout and found that it swelled up or became more painful during your sort of later stage rehab?
No, I was very fortunate. Like, there was very limited inflammation after any workout, and maybe that's just based on the different rehabilitation protocols, right? So, if it's your ligament and your ligament finds they find each other again and heal, like, there's less going on than if you use a tendon, put it through that joint, and then wait for it to ligamentize. So, no, I was fine, and just on the inflammation, while we're here, what was really interesting was Tom didn't want any inflammation drugs. He didn't want any ice, compression, elevation. He said that inflammation's good for this particular protocol. He wants it to blow up like a balloon, and majority of people tear their ACL, here in Australia, your recreational, your community level sports on a Saturday. So you tear your ACL on the Saturday, and of course you can then get up and walk around after about 15 minutes. You might go out that night on the beers, and you're dancing around having a boogie. The next day you get home, and it's you wake up and it's like a balloon. And he said that's great. He said that inflammation brings the cytokines in, and it begins that healing process. So the more inflammation, the better from that initial phase. So I thought that was a really interesting concept. Given we need that inflammation as a stimulus to heal. And but going back to your question regarding any setbacks, I was very fortunate. There wasn't any times where it blew up and I had any issues at all. There were times where I'd be walking along a bit of undulated ground, that the grass sort of hides that, and you'd step in and it'd feel like your knee would buckle back like an ostrich knee, and it was horrible. And you just think, oh, I've done my knee again. It was it would be terrible. But no, I was quite lucky. There was no issues whatsoever. It gets stiff and sore, but I think that was due to the immobilization, and then my maybe aggressive. As I said, I was pushing it in terms of trying to build strength and also trying to build mobility. So that, the two pillars for rehabilitation in my mind, you want to build strength and you want to build that mobility. So as I mentioned, I didn't have full knee, like that terminal extension. So I'd place a dead ball, or a weight plate with a pillow, 40 kilos on the knee. So it would actually push my knee passively into extension. Built up to that, but and it's about pain threshold, and I sort of wouldn't go over a 4 out of 10 if it was that painful that it exceeded that number. I'd scale it back a little bit, but look, I was going for I was trying to get back as quickly as I could.
And where are we now, Steve? How long since you've ruptured the ACL and completed the protocol?
Yeah, so it's now it's 2023. I did it at the end of 2020. So yeah, good 2.5 years.
How's the function now? What
Yes.
back to full playing sports, or fear of the knee, or any psychological issues where you're not trusting the knee? That's very common for people who've ruptured their ACLs.
Yeah, no. So I think the biggest hurdle with the trusting the knee is that week 13 scan, which is the first one after you confirming you've torn your ligament, and you can start to see that these fibers are starting to rearrange in that oblique fashion, and that gives you a lot of confidence. And then I returned to surfing 4.5 months after injury. I returned to playing football 5.5 months, so under the 6 month. And you could say, oh, well, yeah, you can return, but did you do anything? And I'll be honest, no, I didn't. It was I was really trying to get back as quickly as I could. It was the worst game I've ever played. But then the second game, which was the 6 month mark, I kicked 2 goals from 50 meters away on the injured limb. A couple more. I had a shot from 55 meters and just missed. I was tackling, I was stepping, I got into the best players on ground. I had a really good game. And from there, there was never really any lack of confidence. There was one time where I sort of made a breakout on the wing, and I was running down the wing, and there was a player had come off the bench, and he came running across, and I was at full flight, and I thought, oh, do I try and step or do I just go through him? And that was the only time I've ever had any lack of confidence. And look, I decided I'd go through him rather than step him. But I have absolutely no issues whatsoever. Don't experience any knee instability. My knee never gives way. It's never sore. It's like it never happened. It's literally like I've never done my knee. It's incredible.
At all now.
I don't know. Even in 2021 when I returned back to playing football, I didn't think about it then either. Like once I'd regained full functionality in terms of my hops were symmetrical. My lateral one-legged hops was symmetrical, and it's about a 30 centimeter. I think it's about 30 centimeter distance, and you've got to do as many hops as you can in 30 seconds. And I think I was around 55, 60 repetitions on each side. So, it's a fair move, in a fair tempo. There's, I do triple leg hop for distance, single leg, not a problem at all. So, once I'd ticked off all of those, returned to footy with no issues, it was, it doesn't bother me at all.
Terrific. And I guess I was going to ask if you would do it again, but it sounds like if you ruptured your ACL, you think you would step back in and do the bracing protocol, say if it happened on the other leg at this stage, or would you have any second thoughts about doing it yourself again?
Would have no second thoughts if I tore it again. Touch wood. I'd brace it straight away. Just wouldn't even blink an eye. It would be done. Yeah, and it would be in day one. I'd get that Doppler as quick as I could after that MRI confirmation, and bang, I would be in that brace real quick. Yeah.
And have you had many people seek sort of advice from you, and you've given them the same advice, I imagine, since?
Yeah. It's I've had heaps of people reach out. It's I've been spreading the word, and so many people have reached out. A couple have had those bundles that have flipped anteriorly, and unfortunately they couldn't go through with the protocol. Right. But those that have, there was one lady. She actually has, and a few people have had, the one limb reconstructive surgery, the other they've gone for the cross bracing, and their cross bracing leg is stronger than their reconstruction leg. So it's like they wish that they could have braced the other leg, because they've just had so many issues with strength and stability in the knee that's being reconstructed. So it's nice to see that from anecdotal evidence that it seems to be superior in terms of functionality and integrity. It's just on that. It's just refreshed my memory when looking at those functional tests. I was in Qatar, on the Arabian Peninsula, and Aspetar, a sports medicine hospital in particular, and Dr. Rod Whiteley, physio over there, he was nice enough to put my knee under some passive tests to assess the knee integrity, and essentially from that, it does that anterior draw and that shift test, and essentially there was no difference between the ligaments, so they both were similar in their strength, in their stiffness. So it was that was really pleasing to see, and that was the end of last year. So a couple of years after, it's still holding up, and And that was one of the questions, like, is it a ligament or is it just scar tissue? But I guess the answer is, who cares? Like, if whatever's there is structurally sound and it's got the strength to be able to withstand, your sport, your pivoting sports, which is, what you want to return to, then it doesn't matter as long as it holds up and it's strong. Yeah, it's yeah. So that was a really nice test, and I guess the nail in the coffin when it comes to some of the questions raised around, what is it like passively, and what's the knee's integrity like.
Yeah, yeah, yeah. And I guess what a lot of people don't think about is that secondary trauma to the knee of surgery, as you alluded to earlier, with the not only the graft site, but also drilling holes into the tibia and femur and putting screws in there and all those sort of things. It's a massive trauma to the knee that in a lot of ways is even a bigger trauma than the original injury in many cases, and the implications that secondary trauma has for the lack of strength and inflammation and just the structure of the knee, and you're drilling through the cartilage on the top of the tibia and femur as well. So there's all those factors that you don't have to go through if you just brace it.
Yeah, exactly. Yeah.
And we're probably speculating a little bit now, but what do you sort of see for the future of ACL rupture management? Do you think this cross bracing protocol is really going to catch on, or do you think there's going to be other protocols come out that achieve similar results with less difficulty, or do you think that it'll be buried and it'll go back to being just most people have surgery, or what do you think is going to happen for ACL management going forward?
Yeah, well, interestingly, yeah, there were a few cases in the literature where you'd have this spontaneous healing. And when I was over in Qatar, there was a couple of staff at the hospital who went through the protocol, but not the bracing protocol. So they just went through physiotherapy or physical therapy, the rehabilitation, regressed it right back, and they actually had healing of the ACLs as well. So I guess I guess this should give us confidence that we can use other methods rather than going under the knife as a means of, in first case at least, if you can get it to heal, the body can heal itself, and it's sound, then go for it. So I mean, the whole underpinning theory behind the cross bracing, as I mentioned, was you bring those 2 points to the shortest distance. The ligament is nice and slack, so it's got the best chance to find itself. So perhaps that's the best way to do it. But until we investigate, we conduct randomized control trials, we won't be completely, we can't conclusively say. But you'd like to think that there'd be other methods, and I guess it just comes down to what do you want to return to. So if it's high level, elite level sport, pivoting sport, I don't believe there's any that have undergone the protocol as of yet. I've been told by one elite AFL club that the next time they have an ACL, they'll be going for the cross bracing protocol.
Yeah.
Yeah. So had a discussion around that. So, but I mean, the elite, there's a lot more. There's a lot more. Yeah, I can fall over with my ACL, no one cares. But if you've got sports person, a lot more voices in the ear, managers, coaches, parents, everyone giving their 2 cents worth. So, it'd be interesting to see who goes for the first cross bracing at the elite level. But I think that it sort of opens up, and I know that there are others that will say just don't go to 30 degrees, because obviously once you get to that 30 degrees of knee extension and greater, at least to the 10 degrees, that's when it's most taut. So if you can sort of avoid that position, then maybe that also gives your knee a great chance of healing. But again, we need the data to be confident in whether one way is better or not. But perhaps if you don't have, and I know Dr. Cross, depending on what fits your lifestyle, there is some modified versions that he is giving, just depending on what works for you. So yeah, look, it'll be interesting. I think if locking the knee doesn't work for you, then just keeping in mind that 10 to 30 degrees is where it's most taut, and trying to stay away from that for maybe the first 6-7 weeks will probably give it the best potential to heal by itself.
Yeah. Yeah. Okay. Well, I think that's probably a good note to wrap it up for today. And so, yeah, lots of great take-home messages there, Steve, for people who may have ruptured their ACL and are considering their future. So, thank
Yeah,
you very much for sharing your story and journey with us.
thank you for having me. Just mate, I'll just reinforce the message. Just remember, you can always do rehab first and then get surgery later if it doesn't work. You can't do it the other way around. So in my mind, always opt for a conservative or non-surgical approach before surgery. And of course, find a good specialist for ACL reconstruction. Reconstruction, rehabilitation.
Yes. I think that's your knee feels so terrible in those early stages post-op or
Yeah,
post-injury, I should say, that patients tend to think, oh, there's no way I'm going to live my life with this wobbly knee that's swollen and a bit painful and angry. So I just need surgery. But I think that message you said is just calm heads need to prevail. The knee is
yes,
going to start to feel better, and
yeah,
now. And with or without the bracing protocol, 10, 12 weeks post-injury, the knee is going to be feeling a lot better than it is in those early stages post-rupture.
definitely. That is a very important message. Things will get better. Just got to give it time.
Yeah. All right. Thank you very
Excellent.
much, Stephen. It's been a pleasure to have you on. Really appreciate all those insights.
Pleasure's mine. Thank you, Bevan.
Cheers, Steve. See you.
The Knee Gurus, brought to you by Asia Physio, providing world-class physiotherapy care across Asia. Visit our clinics in Tokyo, Singapore, Niseko, Hakuba, Nozawa and Myoko.